we'll go ahead and get started. My name is Leslie. I'm a pediatric nurse practitioner from Gillette Children's in St. Paul, Minnesota. My primary job is to see children between 0 up to age 21 with traumatic brain injury and occasionally spinal cord injury. So what we're going to talk about today is defining traumatic brain injury, being able to identify causes, describing what the purpose of neurocognitive testing is, what symptoms are of concussion. I also want you to start to be able to identify cranial nerves and what they control, distinguish between a positive mechanism and negative mechanism of injury related to the spinal cord, and then we're going to go through the SCAT, the Sports Concussion Assessment Tool. Just want to tell you just a little bit about Neurotrauma Clinic. We started in 2007. We see mechanisms of injury from non-accidental trauma, so child abuse, sports injuries, accidental trauma, motor vehicle crashes. At Gillette, we're fairly unique in that the kids that we see are able to see physical medicine rehabilitation, neurology, neurosurgery, physical therapy, occupational therapy, speech therapy, psychology, social services, and this just shows how the clinic has actually grown over the last few years. Those are new patient visits, so we're running about 650 to 700 new patient visits in a year, so new injuries. Total visits are running close to 2,000, and so that just gives you an idea in the Twin Cities how the awareness of concussions and the treatment that's needed has increased. The CDC estimates that approximately 1.7 million TBIs occur every year, and it is a contributing factor to a third of all injury-related deaths. And 75% of those TBIs are considered mild. This is the breakdown by age. A lot of the slides I have put in more for your information, and I'll actually give you guys my email address if you want to get copies of the slides. This one, TBI by gender, 71% are male, 29% are female. Doesn't feel that way in my clinic. It feels more 50-50 that we see. Majority of patients are treated and released from the hospital. 6.62% are hospitalized overnight. And in the U.S., it costs approximately $76.5 billion a year to help people with traumatic brain injuries. Spinal cord injury estimates, there's about 200,000 people currently living with spinal cord injury. Alcohol has been found to play a major factor in about 25%. 50 to 70% occur in ages 15 to 35 years. Motor vehicle crashes are the primary cause. Falls is the next greatest. And of course, when you have a spinal cord injury, you have neurological impairments. They can affect multiple body systems. Musculoskeletal, respiratory, urinary, gastrointestinal. Lifetime cost of a spinal cord injury is anywhere between $500,000 to more than $3 million, depending upon the injury. I've thrown some crash videos in. This woman actually always rides with a camera, so she can document things like that. I think there's a little bit of posturing. This guy's being just
those are
stupid.
wheelies.
Yeah, he starts to take slap.
Wow.
So motorcycle helmet laws by state. Green is a universal law. There's absolutely no exceptions. The blue, there's partial laws. It is riders and passengers under the age of 17 years, and the gray colored states, so Iowa, Illinois, and New Hampshire have absolutely no law.
Oh.
Who just said been there?
You don't want to watch this?
I don't like to watch people get hurt.
I don't either.
I don't. I'll treat them afterwards. I don't want to see them in the process.
Yeah.
I don't think is Liddy okay?
That bothers me too. I hate seeing them.
I've felt pain. I don't want to watch people experience it.
What we forget about with little kids is that even the little ones, we've got one, there's one coming up, even on a tricycle or a big wheel, they can get hurt.
Oh my God.
She's distracted, not paying attention.
In the grass.
Bicycle helmet laws, purple is absolutely no law.
Yeah.
The rest of the states vary from the 17 and younger all the way down to the 11 and younger. For car seats,
Are they pretty strict about it, those states? Like with the helmet laws, do you know?
I don't know. I do know and I've got a slide on Canada, they actually will fine parents for not putting helmets on kids under the age of 16. Skateboarding, riding bikes, scooters, those kinds of things. So if a child is found without, it sounds like that they're pretty strict. This is a demonstration. It's supposed to be a 9-month-old, and it's just showing rear-facing versus forward-facing and what happens in a motor vehicle accident. This one's booster seat versus just seatbelt for a 6-year-old. So lap belt versus one with a shoulder belt. So child seat, booster seat laws. Orange, 8 and younger. Yellow is 7. And then the Florida is actually requires it only for 3 and younger. United States seatbelt laws. Green are primary enforcement, and blue is secondary enforcement. So secondary enforcement means they can't actually stop you for not wearing your seatbelt, but if they pull you over for some other reason, they can ticket you. And I believe that's how we started in Minnesota, was actually a secondary, and it moved to the primary enforcement. Now the concussion laws are really kind of up and coming in the United States. And how we handle concussions in youth. In the green states, what the laws require is for children under the age of 18 who are playing in an organized sport, whether it's a school-sponsored, they're on a traveling team, it's a community program. If anybody suspects that the child has a traumatic brain injury, they have to be removed from play. They cannot be returned same day. And they have to undergo a medical evaluation. And they have to return to their activity in stages. The law also requires that coaches, parents, and athletes receive education on concussions. And essentially, parents are signing off an acknowledgement that they realize that the activity that their child's participating in can cause an injury. Mississippi is the only state with no law, and the other states have just a variety of different types of laws. In Canada, there's absolutely no concussion laws, though there is one pending in Ontario. Seatbelt, child seat, booster seat, helmets, they have laws for all of those that vary in ages. So traumatic brain injury itself is defined as a complex pathophysiologic process affecting the brain. It's induced by traumatic biomechanical forces, secondary to direct or indirect forces to the head. And we don't always remember that indirect. I had a 16-year-old patient that was in a motor vehicle accident, does not remember hitting his head. He was totally not feeling well. Headaches, dizziness, he was seeing colored spots. He felt sluggish, he couldn't think straight, and he was more emotional. Cried at the drop of a hat. I went into the room to tell him that all of his imaging was completely normal, that everything looked good. I just happened to look at him right in the face, in the eye, and he started tearing up. And he said, this is good news. This should make you feel happy. And he said, but if there's nothing there, why do I feel this way? I said, you have a concussion. You have a brain injury. And he says, but I didn't hit my head. Well, he was in a stopped vehicle, rear-ended at about 60 miles an hour. So even though he didn't hit his head, the brain bounces around inside that skull. One of the things that we used to think is in order to have a brain injury or a concussion, you had to lose consciousness. That's not the case. They're actually finding now that loss of consciousness is a protective factor. And I was actually starting to suspect that the kids who lost consciousness seemed to do better than my kids that didn't. The resolution of traumatic brain injury follows usually a sequential course. I usually see the physical things get better. Physical exam gets better first, symptoms get better next, and then the cognitive falls into place. It's almost always normal imaging. You do not see mild traumatic brain injury on a scan. It happens on a cellular level.
Concussion is a type of traumatic brain injury, or TBI, caused by a bump, blow, or jolt to the head, or by a hit to the body that causes your head and brain to move rapidly back and forth. This sudden movement can literally cause the brain to bounce around or twist in the skull, stretching and damaging the brain cells and creating chemical changes in the brain. What you might not know is that these chemical changes make the brain more sensitive to any increased stress or injury until it fully recovers.
In diffuse axonal injury, the connections between these areas of the brain that are being connected by these tracts are interrupted. This is where the axons are sheared or damaged, and so the electrical transmissions that allow our different areas of the brain to communicate are interrupted. And this can manifest itself in a variety of ways, from behavioral changes down to kids needing a little bit more time to accomplish the same task. So the common issue we have is you generally won't see the deficits unless you put a time limit on it. So things like the SAT is where a lot of this comes into play. So, for us, the purpose of imaging in diffuse axonal injury isn't necessarily for clinical management. It's more education of the parent, education of the physicians, and education of the patients themselves to understand that the changes they're seeing are biologic. There's a reason for them. Because a lot of times these children are going to end up in the school systems and they're going to be diagnosed as attention deficit disorder or conduct disorder. And that's not brain injury. And it's important to understand the difference between those. And so in some cases, it's more education. Hopefully we'll translate that into clinical service, and that will be used to help characterize disability and be implemented into programs, and also be used to help engage and incorporate more rehabilitation and intervention services. But that's our hope for what we're going to be doing with this.
So one of the movements that causes injuries, your acceleration, deceleration, the brain moves forward in the skull, bounces back, and that's your contra coup injury. This is actually an example of one of the problems with youth.
Still stomping.
Is they're taught to lead with their head. With rotational injury, to me, these are the more significant injuries. I see it more, it's the hits that you don't see coming. So the checks that the kids take in hockey, the tackle in football that you don't see coming from the other direction because you don't have that ability to brace. The car accident where your car gets spun around, you didn't see it coming, and you weren't able to actually brace for it. I will keep the pathophys brief. When I was talking about it being on a chemical level, what they're starting to find, what they're studying, is something they're calling a neurometabolic cascade of concussion. And what happens when you take a hit is that it causes a reaction inside the cell, so at a cellular level. The potassium that's inside the cell goes out, the calcium then goes in. And when the calcium goes into the cell, it actually damages the cell's ability to make ATP or energy. And you need energy to heal. You need energy, I tell the kids, to fight with their brother, to run down the stairs, to do their homework, and just overall living. And the brain actually has a decreased ability to make that energy. So the only way that they've been able to study the chemical levels is they actually study it in rats. For some reason, rats' brains are very similar to ours. I haven't quite figured that out. But what they're looking at are different levels of chemicals. This is cerebral blood flow. So it should be at the black line. And it doesn't return to normal until 10 days later. Calcium doesn't return to normal until about 6 days later. So things aren't starting to normalize back in the brain until 1 to 2 weeks after the injury. And we used to say, keep kids out for a week. Keep them out 7 days, let them go back. Well, their brain is just starting to get back to normal by 2 weeks. And so with a concussion, the brain has an increased need for energy, but has a decreased ability to make it. And the cells essentially turn off, become quiet. And that's where we see the symptoms come in. The brain is responding to that extra stress. And so we know that 80% of people, adults and children with traumatic brain injury, are going to be better within 3 weeks. I see the 20%. We We know that, go ahead.
For the graph you just showed, was that like all concussions, or is that just the mild ones or the severe ones?
Mild.
The mild, okay.
There are some things that we know can cause it to take longer for recovery to occur. The younger you are, the longer it's going to take. Females take longer than males. The more injuries you've had, if you have a history of learning disabilities, history of migraines, and recent studies are showing that if you have dizziness on field, even briefly, that person is likely going to take longer than 3 weeks to recover. The brief loss of consciousness is actually a protective factor. We used to think that amnesia was predictive of an extended recovery, but not as much as that dizziness is what they're finding. So this is all age groups. 35.2% are falls, 17.3% are motor vehicle. I'm seeing kind of an uptick in assaults. I just saw a 17-year-old who was assaulted and he's got a fractured jaw right now. The CDC published some statistics looking at 2001 to 2009 causes of injury. Football has the highest number. I'm a little surprised that soccer has more than hockey, because I tend to see more hockey than soccer. For your wheeled activities, bicycling has the highest number. Limited contact baseball. Non-contact activities, playgrounds. I'm still trying to figure out what the 153 in bowling are.
Slip.
I'm thinking just pure slip and fall.
Yeah, that full contact bowling.
The 1800 in golf, they actually included golf cart accidents in there. But you would think somebody, golf ball to the head. I unfortunately had a kid that was assaulted with a golf club. This is called parkouring. I learned all sorts of words from the teenagers. And they're actually, this is quite talented in my mind. And I actually, really strange, I found everybody know what Groupon is? The online coupon things? There was a coupon to go learn how to do this.
I've been watching The Matrix too much.
Yeah.
We've had multiple of these.
You're so stupid, Greg. Get off the car now.
Slam on the brakes.
I had a girl from Laos, 16-year-old, off the top of a minivan, face planted.
Yeah.
Sketchy. So being pulled behind a moving vehicle, skateboard, bicycle, rollerblades, sled.
It's gonna happen. Hell yeah.
Yeah.
Well, nothing happens at that. And this guy's laughing.
Must not have been that bad.
We're not all that stupid.
How many of y'all done that?
Yeah, how many of y'all have done that? Come on, be honest.
One acknowledgement over there, 2. Did I see a hand? 3.
Wait, which one of those
So, we've got the camera going. Just a very, very brief review. Again, like I said, I'll give you guys my email so you can get copies of the slides. So a lot of my slides are just pure reference slides. But I wanted to include the dermatomes. Your dermatomes show what cranial nerves control what part of the body. And if you have just even a basic understanding of what's supposed to happen with each cranial nerve, you'll have a better understanding of what's going on with your patient. Mechanism of injury. Examples of the positive mechanism of injury: high-speed motor vehicle crashes, falls greater than 3 times the patient's height, violent situations occurring near the spine, your gunshots, stabbings, sports injuries, anything with axial loading, so something falling on their head, high impact situations, and then for high risk factors, in particular spinal cord injury is a risk in patients with Down syndrome. They have unstable vertebrae right at the top, and so injuries in patients with Down syndrome can actually cause very significant spinal cord injury. But keeping in mind your pediatric patients and your geriatric patients are all going to look somewhat different. Your fractures can cause instability, loose bone fragments, which can cause disruption of the cord. Your ligaments, tendons, or muscles potentially stretched, compressed, torn, disrupted. And if those ligaments and tendons, muscles are torn, that's what's supporting the spine. And so you have to, consider that. There's dislocations, subluxations, your cord injuries. You can actually have injuries to the cord that are considered concussions. You can have bruising. You can also have an epidural, so you can have a bleed in the spinal cord as well, just like you can with your brain injury. And again, thinking about those cranial nerves and what they control, if those are interrupted, you can actually have some effect on cardiovascular function. Assessing your level of consciousness in spinal cord injury is really similar to your traumatic brain injury, and one of the most important things to remember is how reliable is that person? Are they drunk? Are they high? Are they just so confused? They don't know who they are or where they are. They're having difficulty communicating. And so if you have somebody and you're suspecting a spinal cord injury and yet they're drunk and so you don't consider them reliable, you're going to treat that patient to the max precautions. Assessing function and sensation, palpate over the spinous process. So what I do in clinic is I start right down in the lumbar and I walk my fingers all the way up the spine. And I'm asking them if they're having any tenderness. I'm also looking for them to arch away, pull away, make a face. And this gets really important in evaluating kids who are active in a sport. So you're seeing them on the field, they want to get back to play, and they're not going to be as honest with you. And so watching for those subtle signs of pain is really important. You're going to check motor function, so you're checking strength, having them shrug their shoulders, having them spread their fingers apart, and you try and squeeze them together. You're also going to check for sensation, asking about numbness, paresthesias, so numbness, tingling, pin
The
sensations.
spinal column consists of 33 vertebrae that are stacked together. They can be divided into 5 sections. There are 4 coccygeal, 5 sacral, 5 lumbar, 12 thoracic, and 7 cervical vertebrae. These vertebrae provide stability for the torso. The bones of the spinal column also serve as protection for the spinal cord and the origins of smaller nerves that branch out from the spinal cord to various parts of the body. The vertebrae are connected to one another by strong bands of tissue called ligaments. They are also connected to the surrounding muscles by tendons. An injury called whiplash, which affects the 7 cervical vertebrae of the neck, is most commonly caused by car accidents when the force of a blow from the rear causes the head to whip backward and forward very swiftly. This action can cause tears in the muscles, tendons, or ligaments of the neck. It can also cause a nerve to become pinched between 2 vertebrae, resulting in pain or numbness that may radiate down to the shoulder, arm, and hand. Depending on the severity of the injury, whiplash may be treated with a range of interventions, including immobilization with a neck brace, medication, exercises, and, in extreme circumstances, surgery.
So, traumatic brain injury can cause functional changes. It can affect thinking, sensation, language, emotions. Symptoms can last minutes, days, weeks, months, or even longer. I've had multiple patients who've become suicidal. My youngest is 7. And that's from the injury. I talked to the kids about being more emotional. The example I give is bursting into tears because you can't find your sock. Normally, you just cope and you go get another pair of socks. But you're just so overwhelmed with emotions that it can affect how you're feeling that way. The big issue with being suicidal and traumatic brain injury is that traumatic brain injury can also increase impulsivity. And so, even if I talk, make that contract, you're going to tell somebody, you're going to talk to somebody. Sometimes that impulsivity can just kick in and cause problems. I have kids that start acting out. They're starting to, hit brothers and sisters. I had one kid tell me that just the existence of his brother in the room, his brother just had to walk into the room, didn't have to say anything, look at him, do anything. It annoyed him. When they've looked at high school students, the most common symptom reported is headache, and then difficulty concentrating. But we see all sorts of things. The headaches can be migraine, so headaches that have light sensitivity, sound sensitivity, nausea. The child that I said was seeing spots, those are visual migraines. And sometimes with visual migraines, it's just that. I actually get migraines, visual migraines, and I lose the right side of my vision. It goes blurry. Half an hour. And for some people, that's all that happens. For some people, it transitions into a headache. So it's kind of the aura, the pre-symptom before a headache?
So I've had a few concussions and I get migraines. What I've noticed that I didn't start getting them until after I got my first one is like getting them 6 days later. Is that is that something that's normal?
I tend to see, especially if there's a family history of migraines, and you then get an injury, it just seems to kick those migraines in sooner than later. The kids probably would have gotten them anyway. It just kind of set it into motion beforehand. Sleeping. Some kids sleep less, some sleep more. I had one teenager was sleeping 20 hours a day. Her parents literally had to wake her up to get her to eat. I have kids that are trying to function on 3 hours of sleep. They just can't fall asleep and stay asleep. Sometimes it's because of dizziness, sometimes it's because of headaches, and other times it's just strictly a part of the injury.
Coming up in our centerpiece, concussions, the unique and dangerous vulnerability for teenagers playing sports.
And I went down to the trainer's table, and he was lying there, and he was drifting in and out of consciousness. We called
everybody hear of second impact syndrome?
And they came, they rushed him right into the trauma room, and it was within probably half an hour the doctors came out and said there's nothing we can do.
The phenomenon, second impact syndrome, and young athletes need to know about it. Our centerpiece will tell you about the danger next. Ben Roethlisberger has been put out of a game this year with a concussion, and the Chiefs' Trent Green only now is back in uniform after 2 months. Concussions are a critical football issue. Now, if you're a young athlete or the parent of one, this next number might startle you. According to the American College of Sports Medicine, of 2 million sports concussions each year in the U.S., 85% are never even diagnosed. Another researcher estimates that nearly half of all high school football players suffer a concussion each season. And as David Amber shows us, young athletes are uniquely and dangerously vulnerable to the hits to the head so common in this game.
Friday night, the stands are full and the energy is palpable. The town is Plymouth, Pennsylvania. The school, Wyoming Valley West High. The coach, George Curry. In his 40 years on the sidelines, he's compiled more wins than any coach in state history.
Football is a violent game.
I love this
what you're getting into. It's not a contact sport. Dancing's a contact sport. Football is a collision sport.
For Curry and other coaches like him, football is also a test of character.
You're going to get knocked down. You may get injured. You're going to get injured. That's the nature of that sport. When that happens to you, you'll see kids respond, and they can't wait to rehab it. They're going to do whatever it takes. They can't wait to get back on that field of competition.
3,000 miles away in Costa Mesa, California, Kelly Colby was concerned when her son Matt took to the game at an early age.
I really didn't want him to play football, you know. I thought that it was too dangerous. And, but my father always saw him as a football player, and so encouraged him.
We used to go out in the backyard. This was when he was like about 8 or 9 years old. And I'd throw him footballs and stuff, and he'd make these diving catches. And I said, Matthew, I think football is your game.
Matt Colby played Pop Warner for 5 seasons. By the time he reached high school, he was a big kid with big dreams. But his senior season, everything changed.
After the 3rd game of the year, some of the students told us that he was laying on the floor in the bus, complaining of a severe headache.
He was invincible like all 17-year-olds, and he had to finish that season. So to hear, you know, you can't play if you have a headache, what is a 17-year-old boy going to say in a situation like that? He's going to say, I don't have a headache.
A few days later, Matt was cleared to play by a personal physician, but was specifically told no head hitting. Darren Colby says the doctor, who was not American, misunderstood Matt's sport.
The physician that examined him actually thought that when he said he played football, that he was saying he played soccer. And that's, I think, what she meant by no head hitting, no hitting the ball with your head.
The following game, Matt's grandfather noticed something out of the ordinary after what seemed like an ordinary play.
Partway through the first quarter, he trotted off the field, and I went down to the trainer's table, and he was lying there, and he was drifting in and out of consciousness. We called the paramedics, and they came. They rushed him right into the trauma room, and it was within probably half an hour the doctors came out and said there's nothing we can do.
So part of you is just lost. In that moment, everything changes. And you're helpless. And you don't have, I went really into denial.
The Orange County Coroner's Office found that Matt Colby died of repeated blunt force trauma to his head. But how a seemingly routine hit turned fatal remained a mystery until Matt's uncle spoke with a hospital intern.
She said, you know, it sounds like something called second impact syndrome.
Second impact syndrome is a catastrophic injury to the head that results typically in younger athletes under the age of 18.
Dr. Kevin Guskowitz was an athletic trainer for the Pittsburgh Steelers. He says that second impact syndrome, or SIS, affects only teens because their brains are still maturing. Though the phenomenon is rare, with 100 documented cases in 25 years, he speculates that 4 or 5 times that many have gone undetected.
In all the documented cases, there was an initial injury, typically about 7 to 10 days prior to a second impact to the head. 50% of these cases, this injury results in a fatality. The other 50%, there is some degree of permanent brain damage.
That's what happened to Brandon Schultz, now 29. 13 years ago, before suffering second impact syndrome, Brandon was a high school honors student, an aspiring architect, and a star on the football field. What do you remember most about playing football?
I loved everything about it. I mean, you know, from being in the locker room, you know, even in practices, you know, when I go into the locker room, you know, and be thrown on my pads and whatnot. I mean, as I was putting on the pads, I could already feel, you know, my adrenaline just pumping up and out. God, I loved it.
Brandon's experience was similar to Matt Colby's. After a game, he started suffering headaches. A week later, he decided to play again without consulting a doctor. His mother, Lane Phelan, was in the stands that night.
I remember looking at him, and he was standing there. He had his hand on his head as if it was hurting. He was just in on a tackle and was shook up quite a bit. He had his bell rung the week before. The next time I turned around and looked, he had collapsed on the field, and he was just flat on the ground.
It's a miracle that I'm standing here talking to you right now.
Brandon was in a coma for 6 days, in the hospital for more than a month, and underwent 4 brain operations.
I had watched this young man in a month's time go from 185 pounds to about 145 pounds. He was pretty thin and pretty pale. But you know, it was the first time we'd seen a smile on Brandon's face when he saw his little brother, and I just so can remember that.
Oh, not even!
Brandon is now able to enjoy hobbies like bowling, but still requires assistance in most aspects of his daily life. His short-term memory is impaired, he has partial loss of vision, and he walks with a brace because his brain cannot send the proper signals to his leg.
It's certainly very sad to see a young man with that much promise go through this. It's a great place.
Dr. Mark Lovell, a concussion specialist at the University of Pittsburgh, uses Brandon's case to help warn other kids at his clinic.
Did anybody tell you you were knocked out after this happened?
His medical team sees 50 to 70 high school football players a week, teenagers like this one, who suffered a concussion just days earlier.
Then we went into tackling drills, and I don't remember anything after getting in line.
There's some controversy regarding whether you actually need a second hit to cause that brain swelling that we see. However, in my opinion, we do see this more frequently after an initial injury. What we're going to do this afternoon is have you take the test again.
Dr. Lovell uses a computer brain exam he helped develop called IMPACT, which measures memory and brain speed and could help prevent SIS. The test, currently used by the NFL, the NHL, and Major League Baseball, can also be found in 900 high schools across the country. What costs are involved in having your IMPACT test?
It's hundreds of dollars per, per an entire high school. So the cost is really minimal. It's the cost of several football helmets.
How serious do you think the problem of concussions are in high school football?
I think it's always going to be there, that threat of a head injury, because of the sport you play. The head injury is part of that game. You're always worried about it. You don't want to lose a good kid because of that. Any youngster that gets a head injury would make it a serious concern.
What do you think kids out there, high school football players across the country, can learn from what happened to you?
I think that they could learn to take every headache seriously. I know that I told, people that my headaches were gone before they were gone because I wanted to play.
You always think, you never want to outlive your children, but you never ever think that you're going to outlive your grandkids. And I don't want to ever see anybody go through this again.
David Amber reporting. Now, experts say the most effective tool for high schools is the use of certified athletic trainers, but less than half of U.S. high schools have them. Matt Colby's high school now has one, but 13 years after Brandon Schultz's injury, his former high school does not have access to a certified trainer. We're standing by for NFL Live Training Company.
So to me, second impact is the scariest. And there are times that I will use that scare when I'm talking to kids and families that I'm concerned about this risk. I certainly don't want to be the one to tell somebody that can go back to play when they're not ready and have this happen. So it's 100% preventable.
Even though she's a good student, Lucy Gonzalez says she couldn't seem to finish some homework assignments until well into the evening.
I sat there and I honestly tried, and I would sit there trying to stare at the paper, and I'd end up reading the same sentence over 5 times, and I had no idea that I did that.
It turns out Lucy was suffering from the lingering effects of concussions. Starting with a soccer injury, she had 6 concussions in just over 6 years, forcing her to give up the game she loved. And Lucy's not alone. Since 1997, the number of high school students treated for concussions has shot up more than 200%. And nowhere are the consequences felt more than at school.
How hard are you finding it to concentrate?
Which is why some experts are now going into schools to put teachers through an innovative program called Concussions in the Classroom.
What we want to do is really go into schools and educate the educators and let them know that this kid suffered an injury and then they're not functioning at their normal level.
Dr. Stephen Cuff of Nationwide Children's Hospital Sports Medicine helped develop the program. He says concussions can leave students sluggish, irritable, and distant, which is often dismissed as typical teenage behavior. But Cuff, who is also with Ohio State University, says it's much more serious. So he's teaming up with athletic trainers from Nationwide Children's Hospital to go into schools and teach teachers what to look for.
And you can't treat every concussion the same, so while most kids will get better within a week or two, there are plenty of kids who struggle for weeks, months, occasionally even years.
Once Lucy's teachers knew more about concussions, they could tell when she was struggling and found ways to help her cope. By doing so, they helped her replace a love of soccer with a passion for art, and not only kept a good student engaged, but helped her excel. At Nationwide Children's Hospital, this is Clark Powell reporting.
Grading scales. Anybody familiar with Cantu, Colorado medical guidelines? Talking about grade 1, grade 2, grade 3 concussions. They used to, these guidelines would provide a definition of mild, moderate, severe traumatic brain injury, provide the recommendations for return to activity. The problem with grading scales is that it relies strictly on the person's honesty about what they're feeling. They're also not evidence-based. They're not individually based. And there's absolutely no concrete data used to make the decision. So a group, they're typically just called the International Symposium, and I would love to figure out how to get myself on that. They meet every 3 to 4 years. Vienna was the first, Prague was the second, and then the third was Zurich. So they meet as an international group of professionals that specialize in concussion and provide recommendations in concussion management. So they're recommending not using grading scales. When parents ask me, well, what grade concussion is this? Is it a mild injury? Is it a moderate injury? What I tell them is I can't tell until they're better. So we talked about that loss of consciousness could be a protective factor. So the kids that lose consciousness but are better in that 2-week period, 3-week period, I'm going to consider that a mild injury even though they lost consciousness. My kids that didn't lose consciousness but it's now taken them 6 months to become symptom-free, I'm moving that more into a moderate category. Or my kids that are a year out, 2 years out. I found these guidelines for field triage of injured patients from the CDC. And I pulled some of their slides. I didn't pull the whole presentation, but I wanted to be able to pull part of it. I don't think you can see this very well, but it'll be in the handout. What's interesting about this is that unintentional injury is the leading cause of death between the ages of 1 and 44. I also find it interesting that suicide is the third leading cause of death in 10 to 14-year-olds. With homicide being the fourth. So this panel that put these guidelines together included professionals with a variety of backgrounds, including EMS, emergency medicine, trauma surgery, nursing, public health research, and automotive engineering. They meet periodically to review their decision scheme, ensuring criteria are consistent with evidence, so research. And so they have an algorithm. They have all of these on their website that you can actually download or order for purchase. And it's divided into 4 steps: the physiologic criteria, anatomic criteria, mechanism of injury, and special patient or system considerations. So your physiologic criteria is looking at your Glasgow Coma Scale, blood pressures, respiratory rates, and then it gives you the decision of, is this an immediate transport, or can we go through the rest of this scale. Since these are really hard to see, I am going to move through them and have them for you just as handouts. You have to bear with me with it's been a long time since I had my EMT, and so I'm now, for those of you that came in late, I'm a pediatric nurse practitioner in St. Paul, Minnesota, and I see kids with traumatic brain injury. And so what I want you guys to understand is how to look out for, it's really easy to take that unconscious patient and decide what you need to do with them. You need to load them and go. It's that kid that walks off the soccer field that just doesn't feel right, or just doesn't look right, or just isn't acting right, and knowing what to do with them. And how to figure out, for the kids, it's almost figuring out whether they're lying to you or not. The kids whose eyes are moving in all different directions, but no, I'm not dizzy, or they can't walk in a straight line. And so I wanted to talk briefly about cranial nerves, your motor exam, coordination and gait, reflexes, and sensory. And what I think, in looking at what I do versus what you do, it's very similar. We're just using different terms. Your motor exam, you're looking for abnormal movements. Are they not using one part of their body? You're also looking at muscle tone. Everybody, in doing exams on each other, you know what normal tone feels like. And so if somebody has decreased tone, they're floppy. It's like picking up that floppy baby. You're testing your strength. So when I'm testing strength, I have them shrug their shoulders up and I push them down. Arms out like this, in like this. Have them bring their leg up, I'm pushing it down. I have their legs kick out and back, and then their feet up and down. Really quick. Coordination, I do finger, nose, finger. Have them do their heel to shin. So they're putting their heel on their knee and dragging it down. If they can't do that, there's something off with their coordination. Romberg testing, feet together, arms out. I have them put their palms up and I have them close their eyes. Are they able to maintain or are they swaying? Are they walking normal? Do they have a heel to toe gait? Can they turn around? Tandem gait is strictly heel to toe, walking in a straight line. As some of my kids will say, oh, you mean the drunk driving test? I also watch them walk on their heels and their toes. Do you guys do reflex exams at all? Okay. In clinic, I'm checking biceps, and so I'm checking right here. Triceps is the back of the elbow with the hammer. Brachioradialis is at the wrist. Your patella is your knees. Your Achilles is the back of your heel. And so I'm looking primarily that they're equal. Everybody's different. I get kids, I've learned to hold the foot when I'm doing patellar because I have kids that pop it out. But as long as they're popping it out both sides and it's equal, I'm not as concerned. Upper extremity reflexes are really hard to get, and it takes a lot of practice. I'm actually quite surprised most times when I get them. With your sensory, can they feel? So can they feel your touch on the sides of their face? Does it feel the same? Running your hands down their arms, does that feel the same? I found this. It's a neuro exam done by a paramedic intern that'll walk you through it.
Hello, my name is Lisa. I'm a paramedic intern for Pro Mass at Cambridge, Mass. Today I'm going to be doing a neurological exam. Alright, first I'm going to check sensation in his face, checking his cranial nerves. Can you feel this equally?
Yep.
Can you feel this equally?
Yep.
And this equally?
Yep.
Okay, good. Can you give me a big smile? Stick out your tongue and say ah.
Ah.
Okay, good. Can you say the sky is blue in Boston?
The sky is blue in Boston.
Okay, good. Alright. I'm going to check his ocular motor muscles. Can you try to shut your eyes and I'm going to pull up on your eyelids? Okay, good. I'm checking for nystagmus. Okay. Making sure they're equal, reactive, and accommodating. Okay. Alright. I'm checking his fundus.
I don't even check the fundus.
Alright, this fundus appears to be normal. I'm checking the fundus on this side.
checking the fundus is extremely difficult, and even our neurologists will send them to ophthalmology.
Here's normal.
The fundus is checking the optic disc, so it's looking at the back of the eye.
Can you hear this?
Yes.
Can you hear that?
Yep.
Can you feel that?
Yep.
Can you feel that?
Yep.
And you're never going to do all of this.
Well, how do you know kids not lying?
Can you feel that equally throughout your face?
You don't. I actually recently had a kid that audiology
Can you
picked
hear
up
this?
that she actually was hearing
Can you
it.
hear this?
I mean, if you,
Can you hear this?
if I see you
Yep.
slap it,
Can you hear this?
I hear it.
Yep.
And this?
Yes.
Yep.
I live
Alright, can you push up against my hands and shrug your shoulders? Alright, good. Cranial nerves 2 through 12 are grossly intact. Alright, can you hold out your hands like you're holding them to a pizza box? Close your eyes. We're going to wait 20 seconds to see if he has any pronator drift.
So pronator drift is if their arm starts to drop down and
Alright,
rotate
open your
in.
eyes. Alright, can you pick up this hand again for me? Alright, I'm going to have you touch your nose and then touch my finger. Touch your nose, touch my finger. Touch your nose, touch my finger. Touch your nose, touch your finger. Okay, good. And with this?
And for some people, you have to explain that several times.
Touch your nose, touch your finger. Touch your nose, touch your finger. Alright, good. Now can you put your fists together in front of your chest? Alright, can you pull towards yourself? Push towards me. Push up. Push down. Good. Can you squeeze both of my fingers? Right now we're checking for strength, sensation, and tone. Thank you. Can you take this leg and pick it up and put it out? Okay. On the opposite leg. Okay, good. Can you put your legs towards you? Out towards me. Alright. Can you pick up your toes for me? Down on the gas pedal. Alright, good. Now we're going to assess his reflexes. Checking his arm. Just relax your arm for me. Alright. Okay, good. Checking this arm.
That's bicep.
Okay, good. Bring his arm up and back. Just relax for me.
People can also overthink that. And so you sometimes have to use a distractor technique. Have them count back by sevens. So they're thinking about something else.
Good.
And so you can then get the reflexes.
Hand. Good. Good. I'm going to check his patellar reflex. And this leg. Good. Back his Achilles tendon. And this foot. Okay. I'm going to check first at the Pensky sign. Bring it up and over. Okay. On this side, checking for Pensky sign. Bring it up and over. Good. Now we're checking his gross motor. Can you take your foot and rub it down along your shin on the opposite leg? Now on the other side. Okay, good. Can you walk 5 feet in front of yourself, heel to toe? Looking up. Alright, turn around.
And you're going to get the patient that says, I couldn't do that anyway.
And walk on your
I wouldn't have been able
heels.
to do that normally anyway. Which may absolutely
Turn around,
be the
walk on
case.
your toes.
But many of my patients are surprised when I have them do it when they're better, how much different it actually was.
Can you put your arms out like this for me? Bring them back and forth really quick. This is checking for any dysdiadochokinesia. Alright, and the opposite way.
Done. Coordination.
We now see that all the spinal nerves are intact. This concludes
So
my
part of what you're getting when you're doing that is their ability to follow directions. Are they listening to you? Are they, when they're speaking to you, are they making sense? Are they able to follow the steps? If you give them in, sometimes you have to give somebody one step and then give them the next step and then give them the next step. Most people should be able to follow several directions at one time. How many have learned cranial nerves before? So, I learned by silly things like mnemonics. And so, for the cranial nerves, if you learn on old Olympus, towering tops, a Finn and German viewed some hops, that gives you the cranial nerves. And whether that cranial nerve is sensory or motor or both is, some say marry money, but my brother says big brains matter more. So cranial nerve 1 is your olfactory, it's your smell. We don't even test that in clinic. It's very rare. And you have to have special bottles with different scents in it to actually test it. It was really weird. I had 2 teenagers in one day that had lost their sense of smell. And the way they describe it is nothing tastes the same. They can't taste their food. And the danger when you lose your sense of smell, of course, is you can't smell smoke and you can't smell natural gas. And so then there becomes some safety issues. Go ahead.
Can you go back one slide for 1 second? Sorry, that's up.
That one?
Yeah, thanks.
So your cranial nerve 2 is your optic nerve. And you're already looking at that. You're looking at whether they're able to see, their pupil reaction, and whether the pupils accommodate. Good? Okay. You're actually looking at your cranial nerves 3, 4, and 6 when you're doing that extraocular movements. So can they track your finger? It's really interesting when they can't. And what I see is they know that I'm coming down. Their eyes jump. You can tell that they lost track of my finger. With convergence, it's can they go cross-eyed. I actually, with the OAC group, did part of this lecture and demonstrated convergence on one of the kids. And she had actually had issues with it. And what I saw is her eyes came in, then her left eye couldn't maintain it, bounced out. And then came back in and bounced out. Your trigeminal nerve, your cranial nerve 5, is sensory. And so can they feel the same? And can they clench their teeth? And the best way to do that is to use a tongue depressor, have them bite down on it, and you gently try to pull it. If they can't maintain it, there's something wrong with that cranial nerve.
Does that mean that that lady had a damage, or is that just something people can't do?
Some people can't do. And what you see with that is, I see it a lot in kids with ADHD, that it actually has more to do with their ability to coordinate their eye movements than it actually has to do with their attention. Your facial nerve, have them smile, have them frown, puff out their cheeks, raise their eyebrows. And another way to check is to have them close their eyes and not let you move their eyelids. Auditory, you're not going to have the tuning fork. Sometimes I can't even find the tuning fork in clinic. And you just rub your fingers together. And again, you're relying on their honesty, but you're asking if they can hear those rubs. Your glossopharyngeal and your vagus nerves, you just have them say ah. And you're looking for the back of their throat to be symmetrical and their ability to say ah. You're going to catch the cranial nerve 11 with the shoulder shrug. Can they do that? And can they maintain it when you're pushing down? Neck strength against resistance. Have them turn their head and try to keep them from turning it back and seeing if they have strength. The cranial nerve 12 is sticking out their tongue. Does it come out straight And can they move it side to side? And I put the grid. I'm skipping that. So this is an example of nystagmus. Do you see the bounce? It's really subtle. This way is pretty smooth. Do you see it kind of jerk? That's abnormal smooth pursuits. And so that's when you're doing either I do it as an X. You can do it as an H. This one's torsional, this next one. And you don't need to know the types. I just wanted to show you different types of abnormal movements that you may see. And some people can have nystagmus at their baseline. Just like some people have pupil sizes that are different. And I can always tell the people that have abnormal pupil sizes because when I go take a step back and take a look at them, they're like, yeah, they're two different sizes. And so asking the patient when you're seeing something like that. Upbeat nystagmus.
Something I have you do is just hold your hands right out in front of you, palms up, hold them still, close your eyes. You look for any type of drifting or pronation. There's none. If you were to have a pronator drift, which would be an abnormal response, it would look something like that. She has evidence for that.
Okay. You bring your chair. So I'm going to walk through. When I was in school, I never thought I was going to be able to do a neuro exam in under an hour with all the different steps to it. What I won't be able to do is actually, I don't have a light to check his pupils, and I don't have the hammer to do the reflexes, but I will do everything else. And so what I'm doing is looking at them and looking to make sure that everything looks symmetrical. I have had patients with a cranial nerve palsy where the one side of their face is drooping, which again can also be normal. So asking the patient or asking the family member that's around. And so what I first do is check pupil sizes, checking for accommodation, and I'm checking to make sure that the light lands in the pupil at the same spot. Then I check extraocular movements, like that. And then convergence, and just have them follow it all the way in. And some people actually can't do it, but if they're telling you that they couldn't do it normally, you still have to treat it as abnormal because you don't have the proof that it's actually their baseline. Have them raise their eyebrows up, show me their teeth, stick their tongue out, stick their tongue in their cheek, making it sure that that they're pressing against my fingers so they've got strength in the tongue. Shrug your shoulders up, don't let me push it down, arms out like this, don't let me push it down, in like this, don't let me pull. Bring your knee up, don't let me push it down. Push your legs out, in, feet up, feet down, make a finger, touch your nose, touch my finger. And sometimes I need to say accuracy, not speed, especially with the boys. Get up. Walk on your tiptoes for me. Walk on your heels. And walk like you're in a balance beam, heel to toe. Put your feet together. Arms out in front of you, palms up, close your eyes. And then like the added benefit is being able to say, keep your eyes closed, I'm gonna try and push you over. Don't let me move you. And I go from that side. And I've learned to be on the side to catch. One time I wasn't. Push there, and then from behind. Okay? That's my neuro exam. That's it. You know, there's pieces that I didn't do. You know, it didn't cover every single detail, but it gives me a really good idea of where they're at. Do you guys want to take a break? Let's take like a 10-minute break. Come back at 9:30, and then we'll go through the sports concussion assessment tool.